Good afternoon. I'm here today along with the Speaker of the House, Speaker Jones, and Representative Neely, who also happens to be a physician, to talk about some new initiatives that Dr. Senator Shaaf and I have been working on, along with Representative Neely, to try to improve healthcare services in our state. We know that healthcare availability in our rural areas needs some reinforcements, and the issues of transparency and increased access to care are very important to us. We have a combination of bills that we've worked on diligently over the last few months that will increase price transparency by allowing patients to discover what their health services will cost before they actually have those services performed. These provisions lower healthcare prices through competition. They will increase access to providers, particularly in our rural settings. It will increase the number of providers available to patients and reduces monopolies that can have the effect of improving cost. Certain provisions will provide the state with better data for more informed decisions and for better outcomes related to our state's Medicaid population. It also reduces some bureaucracy and gives Medicaid patients incentives to help lower costs to the taxpayer while improving the outcomes for care. Some of these provisions also reduce frivolous lawsuits that continue to be a burden on the medical system, and fundamentally provides fixes to what is in many ways a broken healthcare system. This combination of bills won't keep patients in the dark about their health choices or health costs. It won't grow government bureaucracy. It will not protect further monopolies in healthcare, and it won't perpetuate the broken system we have now. A couple of the more salient points I want to cover is about a pilot program that we will be proposing for our Medicaid population. I'm of the opinion that we should try to improve our Medicaid services before trying to expand them. The study that came out of Oregon demonstrated that just expanding a patient population into a typical Medicaid service program doesn't really improve health outcomes. It does increase the utilization of the emergency room and increase costs, while not really impacting healthcare quality and outcomes. So we're proposing a pilot program that would use health savings accounts as the fundamental cornerstone, and we would distribute funds on a risk-adjusted basis. In other words, the sick ones get more, the healthy ones less. And from that health savings account, they would purchase a high-deductible plan and then procure their primary care services in a number of ways, giving patients choice. This empowers patients and also can improve outcomes while saving the taxpayer money. Under provisions of this, it would also allow for dental care and physical therapy services. And the physical therapy services would be available if we're referred by a physician licensed in the state. The incentive to keep costs down comes by allowing patients to keep a portion of the savings that accrue over the course of the year. In addition, health information exchanges that will be available in the pilot area program, these are organizations that allow the health records of individuals to be shared, so that an emergency room doctor at 3 o'clock in the morning can see the health record of that patient and identify and view studies and lab work that was done the previous week or previous month that's currently not available to a physician in that situation. That will reduce redundancy and repetitive testing and improve care and lower costs. I also have proposed that we use these health information exchanges to provide data that allows us to target traditionally challenging patient populations to take care of. And the three that I've spelled out include premature birth, frequent users of the emergency room, and chronic pain patients. By using the data available from these health insurance exchanges or health information exchanges, we can target those populations with effective treatment programs. I don't believe that expanding managed care statewide is really the best option for serving our Medicaid patients optimally. I think that really wrings out the last bit of cost savings or cost compensation from providers while not doing anything for quality of care, and it provides a lot more bureaucratic hoops for doctors to jump through, and the result is just rationing care. Also have a program to bring more availability of health care to rural areas using a concept called assistant physicians. This would be physicians that have graduated medical school, passed step 1 and step 2 of their boards, but when they went through the process of trying to match to a residency program, they weren't successful at that. And then there's a supplemental program. It used to be called a scramble, now it's called a SOAR, which is another opportunity for them to match with a residency program, and still a number of qualified physicians who've passed their boards, step 1 and step 2, can't find a residency. This proposal is to allow those individuals to come to the state of Missouri and work under a licensed physician in a collaborative practice arrangement similar to what our nurse practitioners and assistant physicians work under now. But with the one caveat that these individuals, these graduate physicians, would be required to work in either a rural or an urban underserved area, or in the pilot program for Medicaid that I've described. There's also a provision called any willing provider within this set of bills, and it helps to make good on the national promise that was made to patients that if you like your doctor, you can keep your doctor. This would allow that if a physician is willing to take the reimbursement that is offered by a particular insurance company and abide by the other terms of the contract, and if that physician is duly licensed and able to practice medicine in this state, that he would then be eligible to participate in this program. We think that would lead to a lot more patients actually being able to keep the doctor they like. There are a couple of provisions regarding medical liability that are included as well, including something called early offer and another commonly referred to as loser pays. I think with that, I will conclude these remarks and be happy to answer any questions.
Does this expand Medicaid eligibility?
As this bill is currently proposed, it does not expand eligibility. It strives to improve the quality of care and the access to care for those individuals that are currently.
Why not?
It's my opinion that we should try to serve those who are really the most vulnerable and most needy. We have eligibility levels for women who are pregnant and for children that are higher than many other states. And in my view, those are the ones that are the most vulnerable. If we expand, there's a great deal of ramifications of expansion from a fiscal standpoint, but just from the standpoint of diluting the resources available for our most vulnerable populations, the ones we just described, as well as the aged, blind, and disabled, it would reduce the resources we have available to care for those who are the most vulnerable and most needy.
Mr. Speaker, the governor has said that this will actually save us money if we expand Medicaid because it's in the Constitution at the federal level. Is that a bad deal for the state not to bring in money?
Well, it's largely a misnomer, and it's largely misleading. I'm here today not to say that I specifically support every single provision in every single one of these bills that Dr. Shaaf plans to file in the Senate and that Dr. Frederick plans to file in the House. What I am here to say is that I globally support the propositions that these gentlemen are making, and I think it's important to recognize that we have seen now what happens when you entrust healthcare reform to bureaucrats in Washington, D.C. and to special interest groups. You get a disaster hoisted upon the whole nation. And many of us gave warning signs and thoughts as to what would happen when Obamacare passed. Nearly every single one of those predictions is coming true. Healthcare premiums are skyrocketing. I cannot look at the national or even the local news any day now without hearing about a family, a business owner, a company that is having to drop health insurance, whose premiums have double, triple, and I heard a woman's story today, quadruple. This was a lady who has lupus and who very much liked her health care plan. She can no longer afford it now. Obamacare is limiting choice. So for those who said this was going to be the great nirvana of healthcare reform, people now have less choice. They cannot go to the doctor that they want to. In fact, President Obama was awarded the lie of the year last year for making that inaccurate statement. States that have expanded Medicaid are getting additional bills for Medicaid. About 3 weeks ago, the state of Delaware, which expanded Medicaid last year and was told that it would cost X, was sent a bill by the federal government saying, state of Delaware, you now need to send in $25 million extra dollars. I imagine the state of Delaware, which is one of our smallest states in the nation, probably has a budget, I would imagine, below ours. I'm sure that's going to be a huge hit on their budget this year. Additionally, as Dr. Frederick reported, the state of Oregon, a major study just came out which showed that Medicaid expansion does not improve healthcare outcomes. In fact, people are now flooding the emergency room and driving healthcare costs up like never before. So the idea of handing healthcare reform over to bureaucrats in Washington, D.C. and special interest groups, I think the nation now admits is an absolute failure. In fact, just this week, the president himself said he may consider delaying the individual mandate, the key cornerstone of the bill, till after the 2016 elections. Okay, we can all talk about how cynical that statement might be. But what should we do? Over the years, Republicans have Republicans and independents have again and again said there are free market ways to reform the healthcare system. The media has largely ignored those. Congressman Paul Ryan has had numerous proposals. Other Republicans, both in the U.S. Senate and the U.S. Congress, have had numerous proposals. We've had proposals here in the state of Missouri. We passed one of them called the Prompt Pay Act a few years ago. I was the House sponsor of that. I think it's time that states put healthcare reform, that states do need to act. If there was one lesson we learned from all this, it's that states do need to act, do need to have proposals. What better way to reform healthcare than to do it on the state level, where states are the laboratories of experiment and positive change, and to actually have leaders in the healthcare industry who have devoted decades of their lives to actually serving patients who have dealt with Medicare, who have dealt with Medicaid, who have dealt with private pay, who have dealt with health savings accounts, to come up with a plan to improve access to care, to make sure our current broken Medicaid system, which if you ask any expert in the field will tell you it's billions of dollars of wasted money every year, and to make sure that people actually get access to good quality health care. So I think that putting an additional $1 billion Band-Aid on a broken system is not the way to go. I think the way to go is to look at some of these components, some of these propositions that are before us. States that have employed some of these have seen significant changes in positive ways. The state of Louisiana is one example of that. Governor Bobby Jindal has done incredible things in reforming health care. There's other ideas, and so I think this is the way to go. This is the way to improve access. This is the way to drive down costs. This is the way to take care of the nearly 1 million Missourians who are already on Medicaid and make sure that they're getting the care that they need.
There's not going to be expansion this year, you're saying?
You know, what I'm saying is I want to look at healthcare transformation. I've been saying that for over a year now. I've moved bills forward in many different ways that would do that. You know that we expand Medicaid every year in the state of Missouri. Every year, the budget people sit down and say, we have to come up with $100 to $150 million in new funding for our current Medicaid system. So there already is Medicaid expansion built into our budget every year. In addition, there are approximately 100,000 Missourians that are eligible for Medicaid right now today. All they have to do is go and enroll. What I am saying is that we should not be part and parcel of this federal overhaul of health care, known as Obamacare, which has this Medicaid component, which is going to end up bankrupting states that are foolish enough to think that pouring billions of more dollars into a broken system is going to somehow improve access or care.
Doctor, let me ask you from a medical standpoint, there are at least 200,000, maybe 300,000 Missourians that would receive government coverage for their health care that are excluded in the donut hole of the federal health care law from getting the subsidies of Obamacare, but at the same time are penalized if they don't have health care insurance. Explain to me, how as a medical practitioner, you are comfortable with saying, no, we're not going to take $1 billion to cover as many as 300,000 or more Missourians for healthcare, basic healthcare coverage?
There's a couple of things. That, first of all, if we do accept federal money, it's not coming from out of the sky. I mean, this is basically coming from China as a credit card made out in the name of our kids. And it increases our federal debt. It increases our debt to GDP ratio, which makes it much more difficult for our future generations to prosper. So nobody's asking the kids now that would have to take on this additional burden what their thoughts are about it. But in terms of the folks that are in this gap coverage, I do have concern about that. But you know, what's happened is the federal health care law has run up the price of health care and health care premiums, health insurance, to the point that it's much more difficult for someone who doesn't qualify for the subsidies that we just referred to. They're going to run up the deficit. If they don't qualify for that, it's because the Obamacare law added all of these benefits and mandates to the policies. So in my view, the whole thing needs to be reworked. And I personally think we ought to have a health savings account for everybody in the country, and you start contributing to it when you're first born, and your grandparents can contribute to it. And at the end of life, you can decide you're not going to be on the ventilator for the last month of your life. You're going to will that to your kids. There are some other common sense solutions that we can use. We don't have to just say, you know, I've heard say, okay, Obamacare is the law of the land. Well, that may be true, but it's certainly not an infallible law. It has multiple problems with it. The premises of it are all wrong. And I think we should reopen that. You know, as a related issue, the dish payment loss that is a part of Obamacare. We didn't break it at the state level. That was broken at the federal level. They should reopen Obamacare and immediately reinstate the dish payments to our hospitals that are providing indigent care. But the concept is we need to reopen this law and look at changes. My personal opinion is we should pull it out root and branch and start over.
You come from, at least your district has got, I presume, some rural hospitals that have expressed concerns about dish payment cuts. Do you have a concern that we have some rural hospitals that may have to close, may curtail services because of dish payment reductions?
I think our hospitals are feeling a lot of pressure, and I think beyond the dish payment or the RACS audits that we really, as a state, should try to do everything we can to oppose. These RACS audits that are occurring are in the name of fraud, but I have talked to a number of individuals who are involved in this review process, and it is not fraud on the part of the medical professions and our hospitals. But they're using clerical errors and miscoding to deny the entire stay. Not to just say you coded it a little wrong, so we're going to reimburse you a little bit less. The entire stay is denied. And this is costing our hospitals more than the dish payment loss is costing us. But I do have concern about both of those areas, but those are federal issues. We didn't enact the law that stopped the dish payments to our hospitals. The federal government should reopen that.
So, I mean, that's the argument that, like, Kip Bond is going around saying, is that these rural hospitals are going to see less if they don't expand Medicaid. I mean, is there no state responsibility there to sort of carry some of the burden, I guess?
You know, the hospitals were all in favor of Obamacare and testified in favor of Obamacare and pushed it along.
The dollars will come from Medicaid, right?
They were hoping that they would get all the insured population and that they would get Medicaid expansion. It just shows to me that the federal government was very authoritarian and arrogant in just commandeering the resources of the state of Missouri and other states by saying, you will expand Medicaid whether you want to or not. Well, thank goodness Justice Roberts still respects the 10th Amendment and allowed states to make their own determination. Because indebting our future generations is not something that I personally want to have my fingerprints on.
So what's the likelihood that in the next couple of years we're going to see rural hospitals, one or more rural hospitals close, shut down services? I mean, how great is this danger that we're facing in rural Missouri?
I come from northwest Missouri, Cameron, and just to go on with the comment about the RACS audit, my hospital, where I'm the medical director of a geriatric psych unit, We had an audit of 25 charts. Every single one of them cleared the audit. I'm just kind of curious what the cost of the entire audit was. It'd be an interesting issue here. So that hospital apparently is running a very clean program. And so you think about this layer of bureaucracy that's being created, outside entities, private enterprise, and I'm kind of curious whether even that enterprise was, that did the audit, if they were even in Missouri, as another side note. But Dr. Frederick hit some very important issues here in regards to some of our indigent people. They're not getting the dental care. If we keep spreading the amount of money, we're going to lessen and lessen the amount that's offered to those totally needy individuals for their dressings, the trachs, the trach care, etc. And we're just not doing those right now. We're presenting the picture that we're providing all of this great care to a number of people. We are not. We need to be reorganized how we're doing these things. And I think that if we have good hospital administrators, if we can lighten the regulatory burden on some of these hospitals, they'll do fine.
Thank you all very much. Thank you.